Okay, so it's noon. We'll get started. Before we begin, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which we now gather. Just a reminder to please enter them in the chat, and as well, please fill out a brief survey that will be. It will let us know that you are present here today. So it's a great pleasure to introduce our speaker today, a colleague of mine from the Division of Cardiology, Dr. Elvin Kedhi. Dr. Elvin Kedhi is an MD PhD who completed his undergrad training at the University of Padua in Italy and his cardiology residency at Antwerp University in Belgium. He also completed fellowship training in interventional cardiology at the Institut Cardiology de Montreal and Erasmus University in Rotterdam. Dr. Kedhi will be developing a new clinical trials program within interventional cardiology and will help grow our advanced coronary intervention and valvular heart disease program. He currently is the Chief of Interventional Cardiology at the MUHC and McGill University. Elvin, thank you so much for being here today.
Thank you, Nadia, for the great introduction. So, it has been since the time that I was a fellow, actually, in the Institute of Cardiology of Montreal, and that was the time when these FFR come out. This fractional flow reserve is basically what it does is it measures how severe is your stenosis, and if you should or should not treat it, its decision is based on this. So, because of this, we have. Let's say that interventional cardiology is a field that is not a very old field. It started in the 80s, but actually become a reality in the 90s. And this is the guy who is the Andreas Grunzig, who developed the first balloon. And it's a very simple thing. You have a stenosis, you open it, you blow it open, and it comes open again. But this was at the beginning a very major breakthrough. Then we had the first stent. It was just a tube, and then you can open it and make it like this. And then, of course, since then, that has been a major development that has required a lot of clinical trials. And I can say that at the moment, interventional cardiology is where is published the most. And although what we do is very simple, it's closed, we blow it up and it's open, and we look like plumbers most of the time. I think that it takes a little bit more than that into what we do. And also there is a need for that because, as you could see, since the time it was invented, now we're talking about, these are numbers from Austria, Switzerland, and Germany. So we're talking about 3,000 PCIs or 3,500 PCIs for 1 million of population, which I think that in the reality of Montreal, we're close, but not yet there. So there is time to grow. And you can also see here how the growth has been over the years relating to surgery. Surgery is what you see. Bypass surgery is in the red, and that what you see on the black is only till year 13. Nowadays, it's even worse. So, this said, we have two approaches. As I started to say, we have the approach that goes through ischemia, and you can do ischemia by a measurement within the vessel. But now we can do it from angiography directly without needing a wire, or we can do it from the CT, where more and more people are having a CT beforehand, and they can already see their ischemic already on the CT. Then we have the intravascular imaging, and the most advanced things here are IVUS and the OCT, what we use nowadays. So this is the plaque morphology strategies. And then you have the combined strategies that are coming now. It's a combination of OCT with a detected ischemia called the VFR. And this is where we're actually also going, which I'm telling you from the beginning, this is where my talk is heading, is a combination of these strategies that will lead us to better results. So, as I said to you, we started on the late 80s, and there are millions of procedures done worldwide. There is an army of interventional cardiology, but we still have studies saying that what you guys do is actually rubbish and it's not needed at all. We can all do this with medications, which probably in the future will be, but I don't think that we are there yet. And what also has been changing in the last time is that a lot of negative trials on FFR. And therefore, the cornerstones of our current revascularization strategy are being put on doubt. So we are in this puzzle of what to do and how to look to it. Is it physiognomy? Is it physiology? Is it anatomy? Is it more than that? Is it morphology? Should we do PCI? Should we do CABG? Should we do medical treatment? And actually, either this is a correct statement, I don't know, but it's clearly not enough. And therefore, I think it's time to rethink the revascularization strategy. So as I said to you, the actual revascularization strategy is based on FFR. So basically what FFR does is measures the pressure distally and proximally to the stenosis. And if there is a drop more than 20% there, then this is called positive. And as you could see, though, this is completely reliable on the amount of microcirculation that is beyond that stenosis. And that's also where it plays and why we believe that it's not possible to do it on angiography, but that's why you need adenosine and create this hyperemia. So the first studies was a deferred trial that it showed that it's true that the non-ischemic lesions you can also leave alone in some time, or stenting or not stenting them gave the same result. So basically, you could also say we can also do those of medical treatment. But the concept of FFR really took ground when it went being applied on multivessel disease, because in multivessel disease, it's more important to understand which of these lesions actually is causing angina, because this is also what it was made. It was created as a measurement, but as a golden standard was used stress testing, that nuclear stress test at the time. So it was actually to kind of let you know which of these lesions now is really causing angina, and should we treat them all, or should we just treat the lesions that are actually causing angina? And that works fantastically. But when you want to do a reduction of death and myocardial infarction just by using FFR, so as I said, the ischemia-guided concept worked perfectly as long as the treatment proposed is to reduce angina, because that's what it was invented for, but it's not sufficient to reduce death or MI. It was not made for. It's just like, if you see, for example, these Vespas here are made to go elegantly through the busy traffic of Rome. But if you try to ask too much from them, then they lose their elegance, and that is not what they are made for. And the same thing is also with the concept of FFR. So the whole thing is about how this plaque progresses. You know, the plaque becomes lipidic, and then it will rupture the first time, or depending on the amount of thrombus that is formed, it will be occlusive or subocclusive. If it's a subocclusive, it will give you an acute coronary syndrome that could be overt or could be completely acute. You don't even feel a thing, but that phenomenon happened. And by healing, if it's a non-complete occlusion, it will create a new stenosis. And that is when they present, the patients then will present to us. And that is where we do this FFR. And we know that when we do an FFR, about 1/3 of these lesions is positive and 2/3 of them are negative. We have always divided the coronary disease in stable and acute. But the nature of the disease, as you could see, is not very different. It's a rupture and healing, a repetitive rupture and healing. So what we call actually a stable angina, it's a phase between two ruptures, or two erosions, or two moments that the plaque is unstable. And actually, this rupture and healing of what we know now being called as vulnerable plaques is the main driver of the coronary disease progression. So I'll show you also this next slide, sorry. This next slide is a beautiful study done from Araki. He's a guy from Harvard. And he shows the plaque progression over time. And this is, sometimes it's not really an overt rupture, or it could be a mini rupture that creates a little bit of thrombus like here. And then this heals, and then it has another one, and then it heals. And you could see that there is like a system of bricks. The plaque progresses up to a certain point ab internis, from inside, but at a certain point it stops rupture and healing. So the rest of the progression will come from ab externis, as we call, from the lumen in. And that is a very interesting mechanism of plaque progression. When I looked at this is a picture I took once when I was in Holland. I used to live in Holland, and this is a flat thing. And this is what you could see the dynamic of this picture tells me exactly what is a vulnerable plaque. And the concept that we've had of these plaques is that they are stable, but actually these are dynamic, and therefore they are vulnerable. And when I see this, of course, I see that with the eyes of somebody who does a lot of imaging. So I see the intima media and some thrombus inside the vessel, with this being the intima media and the vessel wall. But we have now these tools that are coming to the second part of this presentation, these tools that we could see very, very clearly how this vulnerable plaque is. And what I'm showing you here is the classical vulnerable plaque. You have at least 180 degrees of lipid and the lipid progression. And then you could come to a point that the lipid is nothing else. You have macrophages inside. It's like a pimple, and then there are macrophages inside, and these are producing a sort of granuloma that will lease the fibrotic cap that is on top, and these become thin. And that's why we call those the thin cap fibroaderomas. These are very prone to rupture. And we can now, with this OCT, we can very easily see them. That's their morphology. You could see this black here, and then you can measure here, and then if they are less than, actually now the new definition is 75, then there are how they look like. And this is how they look like when they rupture. You'll have this embolization of this necrotic core, and then you'll see the thin flop hanging around. Sometimes you'll see a lot of thrombus on top of it, but this is when the thrombus has leased. Sometimes they will not even rupture. They will just create mini ruptures. You'll see that there is a complete lipidic plaque here, and on top of it, you'll see some thrombus. Because these micro ruptures, the endothelium loses its function, they'll produce new thrombosis. And this is the basis for creating major thrombosis. We know now that 1/4 of myocardial infarctions will not come from plaque ruptures, but will come from plaque erosions. And this is also very important to know, but it doesn't matter much what the underlying plaque is and what is causing that. Now, what I have learned, and this is from a slide that I have done once in a diabetic patients, you could see that these plaques coexist, and the progression of atherosclerosis, you'll have a rupture, you'll have erosion, you'll have an old rupture, you'll have a healed plaque, you'll have some thrombus, and this progression of atherosclerosis is longitudinal, and this before it gets axial. So it first will progress and become long. You've seen those pictures on diabetes patients that have long-standing coronary disease. All the stadiums of this plaque are inside there shown. And this is an important concept. This is when these plaques start to coexist, the old plaques, the healed plaques, and the new potentially dangerous plaques. This is where the danger of having an event becomes much higher. And there is also another phenomenon, because all the times that plaque rupture and heal, they'll send microthrombi distal to the endothelium. And therefore, you could imagine here that if you have a normal myocardium, you could see this is the same stenosis exactly. Same vessel, same size. But if you have these micro scars being formed because of this continuous embolization, rupture and healing, of course, all the time will send thrombosis, small microthrombosis distally, and that will cause, of course, if it's an over phenomenon, we call it as a MINOCA, so myocardial infarction without obstruction of coronaries. But when it happens, sometimes in a silent way, then you have this kind of plaque. It could also lead to plaque failure. And we wanted actually to do a study together with Nadia and Dr. Frederick to show that if we have those kind of patients in the coronary that have a long-standing coronary disease that we now can detect, and they have also myocardial infarctions related to that zone of myocardium, this could be a new pathological explanation, pathophysiological explanation of why heart failure can progress, and or sometimes we have patients with idiopathic heart failure. It's not that idiopathic in some of the cases. So this is also something we'd like to see in the future. So the two important questions is that if physiology is sufficient, or better expressed, is there a risk of death and MI in lesions that now are FFR negative, or other ways called non-ischemic? And the second important question is, because this vulnerable plaque is the driver of future events, what is the prevalence of these vulnerable plaques in FFR negative, or let's say in the non-ischemic lesions? Because the ischemic lesions, we're treating them anyway, and it doesn't matter if it's vulnerable or not, we're treating those. So the question is, what is this in the situation of the lesions that we're not treating? And the answer comes from a very beautiful study. And this is done a Korea and a Japan collaboration. And basically what they did is they, as you know, people more and more now are getting out of the cath lab and doing their CTs. But then when they find something on the CT, they'll bring the people in the cath lab. And when they come in the cath lab, they'll do an FFR. But on the CT, they already look for vulnerability criteria. So in this slide, I just wanted to remember these numbers. This patient had disease on the scan, and they had some features seen there as vulnerability in the scan. And then they come to the cath lab and they had FFR of the lesion. I could see, as I told you, about 1/3 of the lesions is FFR positive, and 2/3 of them are FFR negative. And now you see here is the very vulnerable plaques, a bit vulnerable and not vulnerable. So just focus on the blue part of the columns. It looks like the most vulnerable part of the plaque is also where it becomes ischemic, which is true. But remember that these ischemic are only 1/3 of this non-ischemic. So the real percentage is that when we work with the FFR-guided revascularization, we leave 2/3 of these vulnerable plaques, as you could see here from the numbers. We leave them, let's say, on medical treatment, and they don't have. So what you see here, very small, is actually 2/3 of what you see here. And that is a crucial findings, because the majority of these lesions, so 2/3 of these vulnerable lesions, are left beyond with the actual way of revascularization. And we can also say that the majority of this plaque is located in non-ischemic lesions. So now that we know that these are, what is the impact of this plaque left untreated? And the same trial, the same study gave us also the result. These are the ones getting more events during the follow-up. These are the ones who were also left untreated, but they were not vulnerable, and they were also FFR negative. And these are the ones who are FFR negative, but got a stent, FFR positive, but got a stent. So basically, those who got a stent do better than those that were FFR negative and that were left untreated. So we could say that the majority of events during the follow-up doesn't come from the ones who are treated, but also comes from the ones who were left untreated and were vulnerable. This is an old paper that I've done like about 8 years ago, but the work started much earlier. And this is from the only study that we had at the time with prospective data on echo. We had echo, not echo, but ultrasound, IVUS, in the coronaries. And this is from the prospect trial. I had the chance to be invited in New York from the author of this trial, Dr. Stone. And he gave me this statistician and said, look, if you could find something new. And then I found actually that it's actually the TICFAs, those lesions that now we call thin cap fibroaderomas, that are causing the majority of the events. And they were causing the majority in events in diabetics as well as the non-diabetics. Now, there were some critiques on this prospect study, the original prospect study, not this study, because there was no ischemia detection there. So the FFR was not performed, and the IVUS resolution that we had at the time was not sufficient to say is now a thin or not a thin cap fibroaderoma. We could assume, but we were not sure. So in order to solve that, oh, sorry for the slide, it's just the changing of the computers that gives this problem sometimes. So in order to solve that, what we did a study that we took all patients in diabetics. Why diabetics? Because diabetics are the ones who progress the most. So if you didn't see a signal in the diabetics, then it's no use to do it in the non-diabetics. So we took those diabetics who had treatment of all the other lesions, but they had at least one other lesion that was FFR negative. And what we did the FFR. What was FFR positive? We treated what was FFR negative. We did the imaging, and we did a natural history of what these lesions will give. And we divided them on those with very dangerous plaque versus not dangerous plaque. And as we assumed, you could see that those with dangerous plaque, in about 2 years here, year and a half, had almost 5 times more events than the ones who did not. So there, for the first time, we proved that the impact of MACE beyond the absence of ischemia, these type of plaques, they do matter. And this was also maintained at a long follow-up, so it was just not a thing. So if we now want to have a deep dive on the actual evidence of ischemic and thrombotic endpoints, what are ischemic endpoints? Ischemic endpoints are, let's say, restenosis or plaque progression or lesion progression requiring intervention, while thrombotic are, let's say, myocardial infarctions or stent thrombosis. This is what we come back to this ischemia trial. And this ischemia trial tells us that actually, there was no benefit of treating ischemic lesions with stents. You could also do it with medication for death and MI. And the same thing came also from the FAME2. And the only thing that makes this look like it's positive is that they needed revascularization. But the others, they all had revascularization. So actually, there is no benefit in death and MI by doing PCI following these studies. But what we also see is actually that there is a progression in myocardial infarction, though, in those lesions. And there are some caveats which I'll explain later. Another thing is that what we see here is that both groups have about 20% need for revascularization. And what does that tell me? If you do a Gaussian distribution of how the FFR values are, and you cut 20%, this 20% comes exactly at 0.75. And 0.75, nota bene, was the original cutoff of the FFR. These are the real ischemic people. So these are people that you treat or not. If you don't treat medically, if you don't treat with stents, medications are not enough. But this makes a difference because what we do now, we have about 35% of people that we're treating based on the cutoff of 0.80. While if you bring the cutoff to what we actually knew, the meta-analysis have shown that before already, you could actually take a much more lower cutoff to treat people just because of the chest pain and just because of the need for revascularization of insufficient effect of medication, angina medications on these people. I think that number is close to 20%. What we also see from both trials, and they come exactly with the same numbers, both of them, 0.66, 0.67 of hazard rate. So about 1/3 of them, they reduce myocardial infarctions during follow-up by 1/3 treatment. Treatment with stent reduces it. And that is not new for me. That doesn't surprise me. What surprised me is, why are there still 70% still happening? Where are these coming from? If we treated the right guys, why are these coming from? But I just told you, we're leaving 2/3 of this vulnerable plaque beyond. And that is where these are coming from. So the numbers fall together. There is a theory that I think that because we don't target them correctly, that is what's happening. We're targeting too much maybe of just for ischemia, but we're targeting too little for vulnerability. And this message is not coming also from us, another famous group from Akasaka and Kubo from Japan, that show that this combination of thick fat and lipid plaque, that's where it comes. 33% versus not if you don't have it. These are non-culprit lesions of ACS patients. So it's thick fat and plaque burden combination. Another important question is, now we see a lot of these fibroateromas, which of those are dangerous? Or better, what vulnerable plaque to pursue if we have to? And if we look to, I showed you this study before, but this is also another finding from the same study. Basically, it comes down to having a thin cap, having already an event, so this is not the first time that it's happening, having a plaque rupture, which is logical, that leave a plaque rupture beyond it's probably going to go, or having thrombus. And of course, lipid-rich plaque, as you could see, is important, but not as important. The hazard rates are much stronger for those factors that I told you. And that's exactly what we also from our studies found. If you have accumulation, then you could see also if you're more and more of these factors combine with each other, you could see that the event rates can come over 50%. And of course, the more of these factors combine, the less frequent these are. So there is a logic of understanding what are these factors give you beyond the trend. And this is a accumulation of all the vulnerable plaques together. This is a paper we published recently, last year. And you could see how it, by accumulation of all of these factors together, it goes up. And of course, as I said to you, more of these factors you have together, less frequent are. So basically, you don't need to treat all lipid plaque. You don't need to treat all plaque at all. You just need to treat the plaque and very targeted treatment of the plaque that is really dangerous. And it depends where you put that limit. That's the next thing we're going to do to find out where that limit is. But these are also probably people that will actually, if we see that even if we don't treat them, they might benefit from more aggressive medical therapy. Then probably statins are not enough. Probably they're going to need PCSK9 or other sort of lipid-lowering medication. They're probably going to need the new anti-diabetic medication that also have shown to have an impact on even if they are not diabetics, that have an impact on cardiovascular mortality. So I'm sorry for this slide. It's again the changing from two computers. But as I said, the more you combine these factors, the higher is the risk. And now, if you look to that and you look to rethinking the strategy, as I said to you, you see that there is a lipidic plaque that could have a PICFA or a plaque erosion. These are things that we frequently see. And this is the initial part, and then they will rupture or they will heal. And these are the old rupture or heal or covered erosion plaques. These are also things that we see. And then this is, as I said to you, a repetitive process. And once we come to that intermediate phase. So we have a minimum lumen area that started to reduce, so the diameter of stenosis starting to take off. And we could see that there is a repetitive phenomenon. So the plaque with history, I call it. So you have new TICFAs, new healed plaques, old rupture plaques, the coexistent phase of what I showed you before, or new erosions coming on. And this is exactly that picture that I showed you before in the beginning. And this is the advanced coexistent phase. I call it the advanced coexistent phase. And this is, of course, as this happens, the diameter of stenosis will go. The ischemia also will take off. Of course, the more lumen you take, the more ischemia you get. But it's not the ischemia who's driving it. The ischemia is the result of what's driving it. And I think if you need to treat something, you need to understand what's driving it and treat it, not what it's causing. And of course, the more it coexists and in advanced, the more vulnerability it comes. The more it's inflammatory, the more vulnerability it is. And this is what will also cause events of ACS or need for revascularization. Sometimes revascularization is called as a non-malign event. Of course, I said if you need revascularization, we give it. But revascularization, nota bene, could be a result of a rupture that heals, and that so it's a phenomenon, aggressive phenomenon. It's just not growth of plaque. It's a result of a plaque healing, abrupt plaque healing. So this is what I call the danger zone, and this is why, basing on this, what I told you till now, there is a logic of if you need to rethink the revascularization strategy by combining physiology and imaging. And then you're, of course, going to need to look to the stick-fast plaque ruptures. This, what I told you, the coexistence of these multiple factors of vulnerability. And these are not so frequent. These are about 15% in most of the patients. In diabetic, a bit more, but in the normal average patients, so let's say in a mixed population of diabetes and non-diabetics, these are around 15%. Of course, that is also, you need to address also, let's forget about vulnerability. You need also, as I showed you, to target those who have a severe stenosis that causing a lot of ischemia, the true ischemic lesions that are with an FFR of less than 0.75. So basically, by targeting the true ischemic lesions, you take off 15% from what we're targeting now, and you add that 15% by adding it to treatment of these vulnerable plaques. So technically, you're doing a trade of the gray area, what we call the gray zone of the FFR, with the plaque vulnerability. Of course, this plaque need to be at least 50%. I'm not talking about treating 20% plaques, but because, as I said to you, the FFR is not believable anymore in these plaques. They have had multiple thrombus distally and their microcirculation is deranged, that's where the imaging comes in place. So it's a trade. So we'll not stent more, but just select better. And benefit for, of course, once you have the OCT in place, you could also see that there is a much better result with OCT stenting because you see all the details. It's like making a suit just by telling the numbers to somebody or going to a real shop and he'll make it on your size. Exactly like this is also working with imaging. So this is the strategy that we looked at, the combined intervene trial. This is a trial now that is finished enrollment. It was just finished in December. We had 50 centers worldwide. And what we did here, we did that, we repeated in one arm what is the actual guidelines now, FFR-guided revascularization. And that is the FFR, if the FFR is less than 80, you treat. If not, you put it on optimal medical treatment. That's what we do nowadays. And that is also what came to the guidelines based on the FAME trial. That's how it is in multivessel PCI. Therefore, we took also multivessel PCI and we applied this new strategy. We'll treat all lesions that are less than 0.75, independently what the OCT says. And on the other side, we'll look for this, they need all to have more than 50% diameter stenosis. And the other side, we look if there is plaque vulnerability on OCT. And of course, we also offered stenting done on the state-of-the-art OCT. And so this is now ripening the results. So that we have done the enrollment of 1,220 patients. It was a trial that went from actually New Zealand till Brazil. So all Asia, all Europe, and Canada and South America. Only US did not participate. So we expect actually here a reduction by applying this new strategy of 50% of events, which will be something new in the way of we do this. And what I'll also bring new is that we'll forget about all stress tests, all bicycle tests and whatever. This is actually taking off the concept of ischemia. And why I'm saying this, look at these slides. These are New England from 2010. These are obstructive coronary disease with symptoms and then you have positive symptoms, negative symptoms, equivocal, or no test was done. Basically, neither the symptoms nor the functional tests are telling us anything more than what we actually know. So I think the answer will be a lot of CT beforehand. From and now the CT, it's not only doing stenosis or calcium or not calcium, it's doing much more than that. I'm working with a company that does also evaluation of diameter stenosis, FFR, if you look at the vulnerability, look if there is hemorrhages inside the plaque. So the analysis becomes much more complicated. Look even in the shear stress of the plaque, which is another predictor of future rupture. So the things are becoming with artificial intelligence also very, very interesting. And then I think will also how the future will be, it will have the family physician that will look to the risk factors evaluation, will send the patient for a scan. A scanner will not only do the stenosis, but also do all the artificial intelligence of type of plaque, morphology, ischemia, etc. And then give us the answers here, and probably in a score that we don't even have to think much, because in the end, we're interventional cardiology. We need a yes or no, standard not. That's how we think, sorry. And that's why FFR was very good. And we hope to find a score to say, listen, guys, this is for you, this is not for you. Let the smarter people think about this. And once, of course, this is based on this, we'll come to the lab and then we'll have all our nice tools that will show what type and etc. While on the other side, if it's not for us, then I think that people who are more into the prevention and drugs will have to do the internal medicine or cardiology will have to do their miracles on those patients. But I think this is how the future will look. So this is for the part that I have also a few slides more. This is for the part of just coronary. But of course, in the coronary, we had another revolution in the let's say, where also revascularization is part of it, is that we have kind of split the things, the valves and the coronaries, but 50% of the patients have both of them. And all the studies that we've done now is like valve is better than surgery, or CABG is better or than PCI, but sometimes things are not alone, they come together. And that's what made me think of this trial, the TCW trial. I'll just show you a quick. So, as I said, a good part of patients have obstructive coronary disease and severe aortic valve. And then we know that the actual guidelines recommend SAVR and CABG for those. And we know that the SAVR and CABG has higher mortality than each of these operations alone. Of course, it's a more severe operation, longer block pump time and so on. And we also know that TAVI is now non-inferior or superior to SAVR, at least in patients over 65 years or so. And we know that the PCI is considered equivalent to CABG in patients with low or intermediate syntax score. When the syntax score, when the lesion is more acute, of course, CABG does better. And we also know that the FFR was the gold standard technique to detect ischemia, and that is also valid in aortic stenosis. So it was very logical to think, why should we now not? We could do in interventional cardiology things separately. Why do we have to send patients still for CABG and SAVR? Could we not look to how this will look or at least maybe we could do coronaries and then send the patient for surgery. But we tried to do it very simple, percutaneously versus surgically. And that's what we did. We took severe aortic stenosis. That was the rationale. We sent them for CABG or for FFR-guided PCI or TAVI. And there was a loop there, but forget about this. It never happened during the trial. Is that after the TAVI, you could see if there is still ischemia in ductal lesions, then you can retreat. It never happened. So nobody had ischemia after. And we had a composite F point of all-cause mortality, myocardial infarction, disabling stroke, unscheduled revascularization, valvular intervention, and life-threatening or disabling bleeding. And that, I told you this, it was a pan-European study and was powered for non-inferiority, but if non-inferiority was met, superiority of the test was originally powered for 328 patients. But halfway, the DSMB told us that we should probably better stop with the study because there is a major difference in mortality. They didn't tell us in which arm, but they said there is a major mortality difference between groups. So you need to stop. And that's what we did. And we were halfway, as I told you. These were the numbers at the time. And this was the results of the study. And you could see that this is the CABG and TAVI group. And this is the PCI plus, CABG and SAVR and surgery. This is a percutaneous group. What was important is here that also the MACE was the same. And when you look to this mortality and stroke at 1 year, this is quite different between arms. And that's why actually they recommended us to stop. Of course, it shows this result. It's a limited number of trials, but it's a strong result. And I think still that we need larger trials to prove this and to have the real conclusions. But it opens the way in a way to do the studies. It's a strong, let's say, strong pilot. We had the chance to have this published in Lancet because Lancet kind of sometimes accept this kind of provocative studies that open the way, while New England's more difficult from that. But it was funny that New England sent a mail saying, "Why did you send it to us?" But that's what I had to say to you. I think I'm within time. And if there is room with questions, I'm happy to answer them.
Thank you very much, Dr. Elvin Kedhi. Really great, very interesting. Congratulations on everything you've done to advance this field. That last paper is particularly exciting. Any questions in the crowd? We have a nice crowd here today. Mark, Dr. Roger.
I wonder if you could comment on the inter-observer reliability of CT measurements. Are these sort of reliable in your hands only, or in any interventionalist hands? It's something that's been studied, and they kind of look to a hematologist like posograms.
I fully understand the question.
Yeah.
And it's a great question. It's where we are suffering the most. You've spotted the most weak part of this. There is a lot of variability in interpretation of this. Okay. But the good news is that compared to the previous tool, it's much, much simpler to interpret. So if with IVUS, I call it like the 50 shades of gray, you need to really have an eye to understand how that is and needs much more training. This is much more straightforward because really with OCT, you see. And once you see, it's just a question of understanding more the physiology. If you see just one frame and then say, oh, I measured here, that's not enough. Of course, a plaque is not one frame. A plaque extends over a different frame. So there are some tricks into bringing that to a conclusion. But the good news on that is that we don't have even any more to do that. It's developing so fast that the new version that we have, for example, automatically detects calcium, automatically detects the length of the lipid, and automatically tells you if it's calcific or not. Because mainly the two are the questions that operators need to solve. Is it calcium or is it lipid? Because both look black a bit. Calcium is more surrounded with clear contours, and lipid is like a diffuse black. That the computer does already. I know I cannot disclose, but there are some technologies now that automatically give you TICFA, that automatically gives you also FFR on this. So the next version, we don't have to think, and that's a good thing that you need to give to interventional cardiologists, not to think too much, because we are simple beasts, so we need to have a yes or no, and that's the good news here.
Are there any questions online? Feel free to enter your questions in the chat. Go ahead, George.
So, what's the role for like more advanced lipid management in these patients? There's like 50% lesion that's lipid rich. You could potentially, like you're saying, maybe intervene with stents, but then you're taking a stable plaque and you're potentially making it unstable, and then you're basically pushing on dual antiplatelet therapy with potential long-term complications versus just giving them very high intensity lipid management to try to stabilize that plaque medically.
That's also, I think, what we definitely need to study. Right now, there is a simple and a more complex answer to that. As I said, the way we're using now those medications is just based on lab. It has a high cholesterol, local LDL, HDL, etc. That doesn't necessarily correlate one-to-one with what we see in the practice. And because the other thing is, if we look to the number of people that would require those, it's much larger than the number of people that have reimbursements to get those, because they also have a certain price. And that's why I think that it's the way to approach this also to be, let's say, financially conscious. Because, of course, if you are in a rich population, then you'll start giving that to almost everybody with some risk, and probably they will not progress. The good news and the bad news is at the same time that all studies done with this medications, with all of them, I forgot the name now of the trials, but they are all done in plaques less than 50%. Nobody has tested plaques more than 50%. I think I'd love to do that study. That's what I talked to you about. Yeah. But there is a thing that I personally believe, that when there is this plaque that is progressing, there is a moment that it becomes, it's not let's say, a grade 1 equation, it's more a hyperbolic equation. And there comes a moment that I don't know what the factors are, but that becomes much more aggressive. And I think that this is a phase too late. It's always good to give it, but I think this phase is probably too late to give it. But I absolutely believe with you that the future, as I showed in the slides, is that you're going to have these people looking on CT, and that's where you need to intervene. And that will be probably the end of a lot of interventional cardiology, and probably very sad to say, but if you start doing that, you're not going to have CABG anymore. People are not going to progress to 3-vessel disease. Because I remember the Freedom trial. We put these patients on stress test after stress test. 80% presented with 3-vessel disease. They were 10 years followed by cardiologists. The only thing this cardiologist did for them is to send them to the surgeon after 10 years of treatment. No, I believe that there is it's not that I would say the CABG is bad, it's very good, but you need to do it late in your phase. So because that's the last thing you need to get, and you need to buy time over this period by either medication or where needed some intervention.
Thank you. You showed us some beautiful CT images and exciting to see that technology advancing. How would you use, in your ideal world, if we could, how would you use CT in that sort of primary prevention role?
Well, we were having these discussions not so long ago with some others, and he did this joke to the audience. He said, how many of you are more than 44 years? And the people rose their hands. All of you should go for CT. And that's it. Basically, you need to know where you are. I've used it a lot, and when I was in Europe. And I had also friends in England who have a special clinic that do it with a CT outside, and they see a lot of things. I've seen athletes running marathons, not having zero symptoms. They just come for a check. I said, let us do a CT. You do a CT, they come with a severe two-vessel disease, and you don't even know. While other people were saying, I'm going to find terrible things. They had diabetes, hypercholesterol, smoking, zero coronary disease. And so it's very strange sometimes how things are. And I think that's what we are all learning in this process. And seeing for me is having better decisions than when you imagine things. And CT lets you see things.
So you would say maybe everyone has at least one CT scan at age 45 or 50, regardless of whether or not you
I've
have
had
symptoms?
3.
Okay.
I started at 45, and every 2-3 years I do one.
A CT angio?
Yeah.
Okay. All right. Okay. What about the role? Is there any, CT, obviously, there's contrast, you're using dye, you're using radiation. It's not an ideal screening test. What about the role of MRI? Any comments on that?
Let me disclose that I'm not an MRI specialist. And so I'm not the right guy to ask for that. I'm more of a mechanician, let's say, or a hemodynamician. We look vessels. And you could see things also with MRI, but the resolution is not comparable with the new sort of CTs that you have now, the photon emission CTs that show you the same resolution basically as the IVUS. They're not as OCT again. Artificial intelligence will make them as sensible as OCT, although the resolution is there. The MRI has also one more thing. The MRI needs time. A CT is something that you do, basically the real moment that they take these new CTs is almost, correct me if I'm wrong, but a second or 2. So the radiation that you get is just not such a big dose. It's a lower, I heard that they're flying to, I don't know, to Cuba or so. And I think the resolution and artificial intelligence, if you need to treat massa, you need something that you could do 40 a day, 50 a day. That will not going to happen with MRI. Yeah. You need something that works fast, and that I personally believe that if I will give them the chance, instead of saying a 4th cath lab, I'll say, give me a CT in my lab, and that will treat sort a lot of things much easier than in the tragic that we have now. We'll clean the emergency room. Half of these people don't need treatment. They can go home. And then they will come to us for a lab only when they need something that is needed to be done. So in this perspective, this is my perspective I'm looking to it. MRI has 100 and other beautiful things that gives you much, you can see if they're ischemic, you can see if they're not ischemic. The CT can also do this, can give you basically the FFR. It can also give you from where to where you need to stand. So accurate it has become. But the beauty of it is that it's very fast. Of course, it has radiation, but it's not a major dose. And the new CTs, they just go very fast. This dose is small. So if I would have to choose, I'll go for CT. Without taking, don't get me wrong, it's a great thing, MRI, but CT is fast.
And if you saw more than 0.8 FFR in patients, regardless of symptoms, would you intervene? Or would
More
you
than
push them?
0.8.
Yeah, more than 0.8.
Well, that's what I try to say. It's not that you need to intervene to all of them. Actually, I'll bring the limit to 0.75 because these are the truly ischemic patients. So all over that, I'll see if they have some certain morphology. And then we still need to prove where we think that there is a lot of proof pointing to that direction, but the results will come from this study. And of course, we'll need to see also what is the operator, because the operators had to choose. At the moment, they were not trained for this. They're doing this for the first time. So we'll see, but there are other trials coming. There is another trial from Italy. So we'll see if this kind of game takes over. If not, then we'll just probably just drop the FFR. This, I think, will definitely be that will drop the level of ischemia to much lower. And I think it's still useful to also look to the medication approach to some of these patients, though. This is a lot of things that could happen in these patients, also with medication that could do very good things.
Just a last quick question. What are your thoughts of, because, you know, for patients who have no obvious ischemia symptoms or anything, assuming you can't get a CT scan, what are your thoughts at looking at other places for vascular disease, carotids, peripheral, to get patients on? Should we be more aggressive getting patients on lipid lowering therapy by looking for atherosclerosis in easy or perhaps ways?
There is places this is being done. The indications are mixed. The feelings are mixed also about this because there is no hard proof. You know, the coronaries get sicker because they have the maximal flow from all the other vessels. They are the most used, let's say, vessels, because they need to circulate a big amount of blood over the lifetime, and then with the pulsatility, double pulsatility, the pulsatility of the blood and the pulsatility of the heart contraction at the same time. So these are the first one to get weird. But of course, like carotics would be the second, and the renals. Now we're trying to also look to the renal program. And as you know, these are also what have a role in the hypertension. So that's where we're coming to a complete new thing of hypertension, renal denervation, and there are also new techniques now of a stimulation of the carotids. Stimulation of the carotids for this. So there might be a role. I'll go definitely for those two. For the rest, and it's easy to do because then you'll have the rest is also actually quite often done by the vascular surgeons for patients who are at risk. With Dopplers of the low inferior and so on. But these two, I think, should be part. The carotids and the renals should be part of the treatment. Yeah.
Okay, fantastic. So I think we're gonna thank you so much. I think we'll stop there. Are there any other questions? Thanks, everyone. Thanks, Elvin. Really fantastic lecture. Thanks for answering all our questions and a great topic. I'd like to see you again in a year. Actually, one last question. That study you did that you published in the Lancet, are you going to follow these patients long term?
No.
So there's zero. Okay, that's too bad, because you could imagine that maybe in 5 years you're going to see differences.
Could change.
Yeah, could change, but there's zero plan to follow those. Okay, that's too bad. Thanks, everyone, for joining us. Thanks, Elvin. Fantastic lecture.
Thank you.
Thank you.